My name is Dustin Hadley, and I would like to thank you today for attending my lecture on Childhood Attention Deficit Hyperactive Disorder, or ADHD for short. We'll begin today with the etiology and pathophysiology of the disorder that are still widely unknown. However, it's theorized that around 80% is a result of a genetic factor involving receptor and transporter imbalances of catecholamine metabolism in the cerebral cortex. External influences, such as maternal smoking and alcohol consumption, have also been associated as possible causative agents, and although clinically insignificant, dietary factors such as food additives, refined sugars, and food sensitivities are still being investigated. The physical exam is not diagnostic. However, it could be beneficial for clinicians to assess the patient's developmental milestones, such as motor coordination, problem solving, and time management, in order to receive a rounded idea of the patient's prognosis and possible differentials. A clinician's greatest tool in the diagnosis of ADHD is a complete patient and family history, using either the Vanderbilt ADHD Diagnostic Rating Scale or the Conners Comprehensive Behavior Rating Scale. The Vanderbilt being used for ages 6 to 18 and the Conners for preschoolers. These both can be found in the DSM-5. A patient's symptoms can be split into two categories: inattention and hyperactive. These categories, when asking a parent, guardian, or a school authority, will be asked as so: inattention, does the patient make careless mistakes, have poor attention during activities, not listen when spoken to directly, have difficulties organizing tasks, avoids or dislikes to engage in tasks that require mental efforts, fail to finish schoolwork, loses things, easily distracted, or is forgetful. Hyperactive, on the other hand, would include questions such as: does the patient fidget, not stay seated, run or climb when inappropriate, unable to engage in leisure activities quietly, talk excessively, act as if always on the go, blurt out answers before questions completed, or often interrupts others. These symptoms, once answered yes or no, must occur for 6 months, and 6 of those questions must be answered in either category. And you must confirm these symptoms in multiple settings, such as a school and at home. No labs or imagings are used to specifically diagnose childhood ADHD, but labs or studies are used to rule out psychosocial, environmental, or other physiological factors. These include, but are not limited to, hearing and vision screenings, complete blood counts, sleep studies, cardiac workups, and blood lead levels. Some studies have suggested that children with ADHD could be characterized by functional brain imaging to have atypical frontal striatal patterns with reduced global activation in the anterior frontal lobe. This is hopeful for early or definitive diagnosis in the future. Once a diagnosis is received, the first treatment is based on the patient's age. In preschoolers, you will begin with behavioral therapy, while children 6 to 18 will begin pharmacological therapy as a first line. The stimulant methylphenidate is the first choice of your pharmacological therapy, but the SNRI atomoxetine is a good second choice. Often, both behavioral and pharmacological therapies are used in tandem. Sleep hygiene improvement and dietary changes have also been suggested. The elimination diet is implemented when hypersensitivities are suspected, and the omega-3 fatty acid supplementation has been studied and shown to reduce symptoms. Since genetics play a large role in ADHD, prevention of the disorder of itself is unlikely. However, those diagnosed with ADHD should be made aware that their child may have similar concerns or be at risk of the disorder. Early diagnosis and treatment can prevent progression of the condition and avoid scholarly deficits that often occur. Although rare, suicide is a risk with both pharmacologic therapies. Caretakers should be educated on these risks, how to recognize the signs, and who to contact in such situations. Here are my references, and I want to once again thank you for attending my lecture on childhood ADHD.